Hi and welcome. This educational presentation is based upon management of traumatic brain injuries. Traumatic brain injuries are the leading cause of death in persons under 25 years internationally. The following presentation has been developed based upon the introduction of a new traumatic brain injury initial resuscitation and management guideline within the local health district. This presentation endeavours to educate nursing and medical staff within the emergency department upon changes that have been made to the guideline. This presentation will address what is a traumatic brain injury, types of traumatic brain injury, primary and secondary brain injuries, Australian statistics, consequences of traumatic brain injury, introduction of the new traumatic brain injury, initial resuscitation and management guideline, and conclude with take-home messages. A traumatic brain injury is craniocerebellar trauma caused by an external force, such as contact, acceleration, or deceleration, which often results in decreased level of consciousness, neurological or cognitive abnormality, intracranial injury, or skull fractures. Types of traumatic brain injury include contusions, intracranial hemorrhage, depressed skull fractures, and diffuse external injury. Primary brain injury occurs at the time of trauma and includes the previously mentioned injuries. Secondary brain injury occurs following the trauma and continues for hours to days. For example, hypoxia, ischemia, poorly regulated excitotoxic release of excitatory neurotransmitters, electrolyte imbalance, mitochondrial dysfunction, inflammatory response, apoptosis, and increased intracranial pressure. Australian statistics. In 2014, the Australian Institute of Health and Welfare reported that 107 per 100,000 Australians acquire a traumatic brain injury, with 20% being considered moderate to severe. Traumatic brain injury is the leading cause of death in persons under 25 years and is most commonly due to motor vehicle accidents. Males are 3 times more likely to acquire a traumatic brain injury than females. 30 to 50% mortality rate in those with severe traumatic brain injury, and traumatic brain injury secondary to assault is 21 times more likely in Aboriginal and Torres Strait Islanders than non-Indigenous Australians. Consequences of traumatic brain injury. Cognitive impairment is managed with cognitive rehabilitation and prognostically is specific to the severity of injury. In mild TBI, symptoms commonly resolve within 3 months, while those with moderate to severe TBI often experience symptoms for greater than 2 years. Post-traumatic seizures are acutely managed with phenytoin, however there is no effective long-term pharmacological management. Prognostically, patients often experience disinhibition, agitated behaviour, aggression and irritability. Behavioural problems have no specific management and are commonly chronic. Somatic issues such as headaches, dizziness, pain and sleep disturbance are often managed with long-term analgesic regimes. There is no specific TBI management strategies for headaches and sleep disturbances. An early vestibular rehabilitation and beta-histamine may reduce dizziness. However, many of these symptoms are experienced long-term. Post-concussion syndrome is managed with cognitive and educational strategies and generally resolves within 3 months. Anxiety is managed with cognitive behavioural therapy and pharmacological options such as sertraline and deslofaxine. Anxiety is often individually specific, however, post-traumatic stress may be experienced long-term. Introducing the new Traumatic Brain Injury, Initial Resuscitation and Management Guideline. This clinical guideline is initiated in the emergency department and continues through to the intensive care unit. For the purpose of this presentation, only management within the emergency department will be discussed. Please note that the following practice guidelines are for the purpose of this presentation only and as such should not be utilised as a directive for traumatic brain injury management elsewhere. Airway management. In the emergency department, a critically ill patient with a TBI will have their airway managed by the intensive care doctor. Assessment and resuscitation of the patient should follow the early management of severe trauma and advanced trauma life support guidelines available. Indications for intubation include severe TBI with a GCS of less than 9, rapidly declining level of consciousness, altered level of consciousness, or patients who are uncooperative or unsuitable to safely conduct imaging on. Nature of intubation should be rapid sequence induction with inline stabilisation of cervical spine. Application of a cervical collar and spinal precautions should be maintained post-intubation. Breathing. Titrate FiO2 to maintain oxygen saturations greater than 90%. Aim for a PCO2 of 35 to 40 mm of mercury and an end-tidal CO2 of 30 to 35 mm of mercury. An arterial blood gas should be attended promptly post-intubation to guide respiratory support. Mechanical ventilation settings should avoid high intrathoracic pressures that could potentially impede jugular venous return. Endotracheal tapes, while secure, should not be overly tight to promote adequate jugular venous drainage. Importance of airway and breathing. Hypoxia and hypercapnia are major factors influencing secondary brain injury. Hypercapnia influences cerebral vasodilation, thus potentially exposing patients to increased intracranial pressures. Circulation. Ensure normovolemia, avoiding the use of hypotonic, dextrose and albumin solutions. To maintain adequate oxygen delivery, ensure hemoglobin level is within normal parameters. Aim for a mean arterial pressure greater than 70 mm of mercury until an ICP monitor is placed to ensure adequate cerebral perfusion pressures. If required, increments of metaraminol can be given to achieve targets. Noradrenaline should be utilised once the patient is transferred to the intensive care unit and a central line has been inserted. Note that a single episode of hypotension doubles the risk of mortality in patients with traumatic brain injury. The brain is most susceptible to secondary insults within the first 12 to 24 hours post-injury. Disability. Neurological assessment is to be completed prior to intubation and sedation where possible. Neurological assessment includes GCS, lateralizing signs, signs of spinal cord injury, and seizure activity. Indications for osmotherapy, such as mannitol in the emergency department, include decreased level of consciousness with cranial nerve deficit, such as a dilated pupil. 20% mannitol dosage is equal to 1 gram per kilogram. Deteriorating level of consciousness. ABCD remains the priority of treatment even in patients with a severe head injury. CT brain needs to occur as quickly as possible to facilitate urgent evacuation of mass lesions. In stable patients who do not require urgent surgery, spinal images should also be taken at this point to facilitate timely diagnosis of fractures and decrease the need for further patient transport. Surgery and/or imaging should not be delayed by doing unnecessary investigations or procedures, such as insertion of a central line. In the event that urgent surgery is not required, assessment of the patient should include evaluation of spinal injury and/or clearance of the spine if possible. This assessment and/or clearance should concur with local health district protocol. Indications for intracranial pressure monitoring. GCS less than 9 with an abnormal CT brain. GCS less than 9 and 2 of the following. Greater than 40 years of age, significant hypotension, motor posturing, or a GCS greater than 8 but with severe extracranial injuries, especially if neurological assessment will be compromised by prolonged sedation or analgesia. The decision to monitor intracranial pressures will be made by the neurosurgeon and intensivist. While monitoring of ICPs is not considered urgent, it takes priority over unnecessary surgeries such as long bone fixation. The main changes between the old and new protocols are: airway management remains unchanged. Breathing, rather than ventilating with 100% FiO2 and aiming for a PaO2 of greater than 100 mm of mercury, we now titrate FiO2 to maintain oxygen saturations greater than 90%. Circulation, a HB of greater than 100 grams per litre is no longer required. The new protocol accepts a HB that is adequate to maintain oxygen delivery as determined by the emergency or ICU staff specialist. Fluid resuscitation to achieve normovolemia should avoid use of hypotonic, dextrose or albumin solutions. Management of disability, deteriorating level of consciousness, and indications for intracranial pressure monitoring remain unchanged. In conclusion, the take-home messages from this presentation are: traumatic brain injury is the leading cause of death internationally in persons under 25 years. Titrate FiO2 to maintain oxygen saturations greater than 90%. Ensure hemoglobin is adequate to maintain oxygen delivery. Fluid resuscitation should avoid colloids, dextrose and albumin products as they're associated with poorer patient outcomes in traumatic brain injury. Hypoxia and hypercapnia are major factors influencing secondary brain injury. A single episode of hypotension doubles the risk of a patient's mortality in traumatic brain injury.